Hello and welcome. I'm Karen Eggleston, Director of the Stanford Asia Health Policy Program, and I'm delighted to welcome you to today's webinar. Thank you for joining us. Before introducing today's speaker, I just want to note some of the forthcoming events in our curriculum series this academic year on aligning incentives for better health and more resilient health systems in Asia. On November 11th at 4:30 Pacific time, we have Dr. Vivi Alatas talking about Indonesia beyond COVID. And on November 16th, we have speakers talking about the health impacts of climate change in Asia at 4 o'clock Pacific. And then in the winter on January 10th, we have a special panel talking about demographic change, population aging in China. And on February 17th, a special workshop on measuring the value of medical spending across several health systems. We hope that you'll look at our website if you're interested and join us for some of those events. Today, we're delighted to welcome Professor Julie Scher. She's Associate Professor of Health Economics in the School of Economics and the School of Global Health Development at Peking University. Dr. Scher's research focuses on the design and impact of healthcare payment systems, the economics of health insurance coverage, drug regulations, and trends in medical expenditures. And her research has contributed to China's payment system reforms, as well as in other areas. We'll be hearing about some of those today. Dr. Scher's undergraduate degree is from Tsinghua University, and her PhD is from Boston University, both in economics. Before joining Peking University, she was a postdoctoral fellow at Harvard Medical School. Her work's been published in leading academic journals, including the Journal of Public Economics, the Journal of Health Economics, and she received the Paper of the Year award in 2014 from the US National Institute of Healthcare Management, and has conducted multiple projects for central and local governments in China. If you have questions for Dr. Scher, please type those in the Q&A function in Zoom, and we will discuss your questions later in this webinar. So Julie, thanks for sharing your research with us today. Over to you.
Okay, great. Good morning and good evening, everyone. It's a great pleasure to be invited to share our work. I'm Julie Shi. This work is collaborated with Professor Lei Xiaoyan at Peking University, Professor Henry Mark at Indiana Purdue University, and Chen Zhichen is a student here. We're still working on this project, so your comments and suggestions will be extremely valuable. We know that rising medical expenditure has not been a great concern all over the world, including both the developed countries and developing countries. Policymakers have searched various ways to control cost escalation, in general on two strands. The first is from the consumer side, generally to use the cost sharing ways and health insurance to affect consumers' behavior. And the other strand is from the supply side. There are like sufficient evidence showing that hospitals and physicians respond to incentives. And it is widely agreed that the health insurance payment system would affect providers' behavior. In the 1980s, the US has changed its payment system from the retrospective payment scheme in general fee-for-service to prospective payment systems, and followed by Australia and other developed countries. Since then, there is an extensive literature analyzing the impacts of prospective payment system theoretically and empirically. So, however, the existing literature has mainly examined the impacts on overall expenditures or expenditures by specific diseases, and little evidence has been provided on the effects of expenditure by service categories. So that is, the medical services provided to patients includes a bunch of categories, including like the consultant fee, the examinations, tests, drugs, as well as like nursing care. It is likely that the expenditures on those subcategories would be affected differently by like any policy reform. And further, this change will affect the health outcome differently. So in addition, there are also like few evidence showing how the payment reform changed the medical utilization. That is, we know that expenditure reduction may achieved. The overall expenditure may have reduced, but how the expenditure reduction has achieved through using less quantities of medical care or through switching to cheaper services. So these questions are very important and would have some implications to further policy design. So therefore, our paper tries to fill the gap by comprehensively evaluating a payment system reform in China. The general background is that China has pioneered a type of prospective payment system, namely the diagnostic-related groups, for short as the DRG nationwide. So in particular, in this paper, we conducted two part of things. The first is to construct a theoretical model predicting various effects of the reform, including medical expenditure, quality of care, admission, and hospital revenue. And then we use a large sample of administrative data in a pilot city to empirically test the predictions. We tested a lot of outcomes, including the overall expenditure and examines the heterogeneity and expenditure by quantile, also on service subcategories. We also make the decomposition and the quantity by price, expenditure by price and quantity to check whether the spending reduction is achieved through use less quantity of services or to switch to cheaper services. And in addition, we also examined a few health outcome measures and examined some potential behavior response, including upcoding and cream skimming. As for the contribution, we have two main contributions. The first is that we provide evidence on medical payment reform with a particular emphasis on how expenditure reduction has achieved. As I mentioned just now, the main literature, mainly focused on the general reduction on health expenditures instead of provide like detailed evidence on how those expenditure reduction, if there's any, has achieved. We provide the subcategory evidence as well as the price quantity decomposition. The second is that it contributes to China's healthcare reform, and it also it could also inform other developing countries. Well, our work is not the first to evaluate the payment system reform. As like Karen and Winnie has conducted the PPS program, evaluates the PPS program, pilot programs about 20 years ago. They are the pioneers of this field, and also a few other studies also evaluated some pilot programs in some places. However, since China has only conducted the nationwide pilot reform on the DRG only recently, so according to our knowledge, we are the first to work comprehensively evaluating the impacts of the DRG program. And also our work could also contribute to like providing to learn lessons to other developing countries with similar policy design. So all right, then in the following time, I will introduce the background, talk about the model, showing the data, and show you the results. So first, I'll briefly discuss about the institutional background. So as for DRG, I'm not sure whether the audience is familiar with it or not. It is a patient classification system that classifies the type of patients a hospital admits into diagnosis and procedure categories that predict costs incurred at the hospital. So it's in general a classification system used for payments. It's a prospective payment, predetermined before the patient is admitted. It was developed firstly in the US, and in the 1980s, the DRG was firstly implemented on Medicare in the US, and later many other countries followed the US and introduced the scheme as well, including a lot of developed countries. And in recent years, several developing countries also introduced the DRG payment scheme as well, because those developing countries also face the pressure of healthcare expenditure increase. So in China, as early as 2011, the DRG pilot reform has appeared in the documentation of the central government. And since then, some places have piloted just a few very limited places has piloted the program, including Beijing. However, only in recent 3 to 4 years, the government has extensively piloted the DRG program nationwide. Until now, the number of pilot cities quickly reached 33 by the end of 2020, and it is planned that in the near future, all hospitals will change from the traditional fee-for-service to prospective payment, either DRG or another prospective payment scheme named the BIP nationwide. So that is the background here. In our work, we focused on the pilot city, which is a prefecture level city in Western China. The city includes 9 counties, each of which has several secondary hospitals, including 1 county hospital and a few other hospitals as well. So DRG, the reform was applied in a county hospital. The other secondary hospital remained fee-for-service payment method. So which gives us a benefit of designing a different structure to evaluating the impact. The DRG system applied in the focal city includes 493 diagnosis groups, which cover almost all the hospital admissions, over 99% of the hospital admissions. And the program is applied to all the population covered by public insurance, which is also covered over 99% of the population. The insurance payment to the hospital for each admission is determined by the annual insurance budget in the county and the group weights that are predetermined. So the next page shows you an example. So the patients are categorized into different cells, different groups according to their age, complications, and discharge status. So here are a few of diagnoses I show you. For example, the first 2 is the pulmonary embolism with major complications of comorbidities or without MCC. So we can see that the weight are different. And the total payment on the last column is the product of the weight and the rate. So here the rate is set as 5,000. It's just an illustration. So therefore, for the ER21, the group, the payment the hospital received from the insurance would be 10,148. So that's an illustration. And for other diseases, you can see from the third and the fourth rows, they are like have different weight. They have different weights and times the rate. The rate is calculated according to the current the local government's budget, and they get the final payment. Here, things I like to mention is that later we'll check upcoding. Upcoding is that we'll examine how whether the physicians have coded the diagnosis into higher weight groups. That's to say, for example, for the first two columns, we think that if they switch from the second row to the first row, then upcoding may occur. It says that within a disease group, whether physicians have switched code from a less severe group to more severe group. That's what we define as upcoding. All right, that's the introduction of the background. Then we'll come to the model. I'll just briefly introduce the model and I'll talk about our predictions and ignoring the details of the model. So here is the model. We start from the hospital's payout function. The hospitals choose three parameters. A is the number of patients admitted. Q is the quantity for reimbursable services, and a QR is the quantity for reimbursable services, and QN is the quantity for non-reimbursable services. So here, reimbursable and non-reimbursable is to fit the practice of the insurance design here. Is that the majority of the services are covered by the insurance, but there are still some services are not covered by the insurance. And in the DRG payment reform, only those reimbursable services are accounted in the payment. Those non-reimbursable services are not included and are unaffected by the payment reform. So that's why we separate the different types of services, and also it has different predictions. All right, so the three parameters are chosen by the hospital. Hospital's payoff is accounted by two components. First is consumer's utility, and the second is hospital's revenue minus cost. So the first is that here in the first bracket, the first part is consumer's utility from the reimbursable services. UR captures the maximum utility that's if the appropriate quantity of services is provided to the patient. And here the second part represents the disutility from over providing, because we assume that from fee for service, the providers have incentive to over provide services to the patients. QR star is the optimal quantity, and QR minus QR star captures the over prevention. And lambda here lambda R is the responsive parameter, is the parameter representing how responsive the consumers or the patients react to the over prevention. So if lambda is small, means that consumers are like kind of indifferent or less responsive on overconsumption. But if lambda is big, it means that it's quite responsive. It's quite against the over prevention. That's the design. And for the second term, it's the same. It's the maximum utility from optimal prevention for consumers minus the potential over prevention. And EA here is the number of patients admitted. Okay, the second whole part is the revenue minus cost. Here, the revenue in this project is captures the payments received by the hospitals. Theta here captures the payment reform. ER shows the per episode payment, which is the DRG, and PR times QR is the traditional fee for service, which is where the payment equals to the product price times quantity. So if theta changes from 0 to 1, means that the payment reform changes from the traditional fee for service to the prospective payment, like bundle payment. And those are for the reimbursable services. For the non-reimbursable services, it keeps the original fee for service scheme, so it's unaffected. And the final part is the cost. Here is the cost for providing the consumer patients the quantity of care, as well as here is the number of patients admitted. So that's our setting on the that's our model setting. By like deriving the equilibrium, we first consider the number of patients is fixed, and the hospital is to choose the quantity of reimbursable services and non-reimbursable services, and then we calculate the number of patients. Here are the results for the first order condition. I just put it here. The important what way I like to emphasize is the following predictions. Before that, I like to introduce some notation. The payment reform increases theta from 0 to 1. 0 indicates the fee for service, and 1 is the prospective payment, or the DRG for short. And here, QR hat F is fee for service, is the payoff maximizing quantity of QR when theta equals to 0. And the QRE is the per episode, is the payoff maximizing quantity of QR under episode-based payments. So that's the notation. So our first prediction is that the payment reform reduced the quantity of reimbursable services QR and per patient reimbursable expenditure. It's kind of intuitive because the reform changed the incentive, the price times quantity, to a bundle payment, which means the marginal benefit equals to 0 by when providing additional services to the patients. So the payment reform would reduce the quantity of reimbursable services, and the price remains the same. So the reimbursable expenditure would go decrease as well. That's the prediction 1. Also, the prediction 2 says that after the reform, the quantity of and the expenditure on reimbursable treatment reduce more for patients with higher medical spending under fee for service. This is a kind of like straightforward too. The two graphs shows an intuition. In the model, we do not incorporate heterogeneity on payment health status. So the expenditure heterogeneity comes from the different settings on lambda, which is the responsiveness of over-prevention. So the left figure shows that if there is a big lambda, which means that the patient is quite against the over-prevention. So the original over-prevention would be small. So this figure, I forgot to mention, this figure is the x-axis is the treatment quantity, and the y-axis shows the patient benefit. So here, the point QR star shows the optimal ones, optimal quantity. And in the original fee for service, there will be over treatment. If the lambda is big, we know we'll see that the overprevention will be relatively small comparing to what's shown in the right figure, that when lambda is small, the overprevention will be big. So this causes the heterogeneity and spending. And from the figure, we can tell that after the reform, we'll see that the quantity provided under per absolute payment will decrease greater for those patients with small lambda compared to those with big lambda. So therefore, it explains the prediction too that patients with higher medical spending would generate a higher spending reduction. All right, and for the prediction 3, we talk about something about the treatment benefit. Again, through the figure, we can see that the payment reform does not reduce the patient reimbursement treatment benefit if some condition is satisfied. That's to say, because overprevention is existed before, so even the payment reform would reduce the quantities provided to patients, it does not necessarily reduce consumers' welfare if the reduction of the quantity is appropriate. Okay, then is the prediction for we provide the predictions on non-reimbursable services. So the payment reform increases non-reimbursable treatment quantity QN and per patient expenditure. That's kind of also intuitive. As for the non-reimbursable services, we mentioned that it's not affected by the payment system reform. It remains throughout the time remain a faithful service. So for the reimbursable services, hospitals face the pressure of expenditure reduction. So this will switch to non-reimbursable services to increase the quantity and further increase the total revenue. So we predict that the non-reimbursable services would be increased after the reform. All right, so finally, we try to predict the admission volume and the expenditure together. So here the figure shows the prediction. So the x-axis shows the absolute based payment rate. So we can see that at the prediction 6, when the payment rate is high enough, we will observe that the per episode expenditure increase, as well as the increase of number of admissions. Because the intuition is that the payment rate is high enough, hospitals would also generate higher revenue and per admission, and also admits more patients. So if the payment rate is intermediate, we'll see that the per episode expenditure decreased because there is a fixed payment, but the hospitals would admit more patients, trying to keep the total revenue increase or unchanged. And the left end shows that if the payment rate is extremely low, that hospitals would have little incentive to admit more patients. Also, because the payment rate is low, the per episode expenditure would decrease in general. So that's our prediction on the per episode expenditure and number of admissions. That's all I have in the theoretical model. So in the remaining part, we'll construct the empirical models and to test these predictions. Before that, I'd like to briefly introduce the data. We got 2 administrative data sets from Western City or Western Pioneer City. It includes the health insurance enrollment data, which includes the patient's demographics, and also a claims data, including about 0.38 million insured adults enrollees, which are covered by the UEBMI. Sorry for the abbreviation. It's the Urban Employee Basic Medical Insurance. usually it's for the urban population who are employed by the formal sector. They will automatically enroll in the urban employee basic medical insurance. Enrollment data contains demographic characteristics and claims data, including a lot of details on the admission, includes the diagnosis, expenditure by category, and also a few other dimensions. And the advantage of this data set is that it provides the item level characteristics, including quantity and price for each drug, examination, treatment, and nursing care, which supports us to do the subcategory analysis, also the decomposition. We examined a bunch of measures, including medical expenditure, quantity, price, and etc. All right, as for the analytical structure, first of all, is we focused on inpatient sample because the DRG is applied to inpatient patients. Outpatient expenditure are not directly affected by the payments, but later I'll show you they have some spillover effects. As for the hospital sample, all 9 county hospitals piloted DRG during January to March 2016, during the 3 months in the beginning of 2016. We excluded the tertiary hospitals because we think they are not comparable to the secondary hospital. So the treated group in our sample is the number of admissions occur at 9 county hospitals, and the control group is the admissions at other 7 secondary hospitals. The research period is from October 2014 to September 2017. It covers both the pre and post period. Finally, we end up having about 30,000 unique inpatient patients with about 50,000 admissions. Here we show the comparison between the treatment and control group on demographics, and it shows that they are in general comparable on like age distribution, gender, marital status, and etc. All right, before I show you the regression results in the next section, I'd like to show you the raw conclusion without any controls in the table. So in the table, the left panel shows the conditions before the reform, and the right panel shows the after the reform. We focused on the DRG group, the treatment group, and non-DRG group, the control group. Different measures are provided, including total expenditure, including the reimbursable expenditure, non-reimbursable expenditure. And further, we also show the type A drug expenditure and type B drug expenditure. Here, the type A is general, the basic need drugs, which are more cost effectiveness, and it in general received a total reimbursement in the insurance policy. Of course, the cost sharing would be applied. The type B is considered as like less cost effectiveness. Usually it's more expensive, and patients have to pay additional out-of-pocket expenditure on those type of drugs. So here we can see that the main conclusion is that the reimbursable expenditures decreased significantly, and this expenditure reduction is mainly driven by the reduction on type B drug, which is not cost effective and may have over-provided before the reform. That's our main conclusion in the project. All right, and then I'll introduce the empirical strategy and the results. It's a standard difference in difference estimation strategy, and why is a group of dependent variables. Here, I indicates the individual I in hospital H at time T. And DRG is a dummy variable showing whether it's DRG hospital, whether the admission is occurred at the DRG hospital or non-DRG hospital. And post is also a dummy variable indicating the time of the reform. X is a group of control variables. Alpha H is the hospital fixed effect, delta T is the time fixed effect. And our standard errors are clustered at the hospital level. All right, again, before showing the regression results here, I'd like to show the raw spending patterns before and after the reform. So as mentioned, the reform is progressively is gradually implemented from January to March in 2016, which is in the shadow area. So the green lines shows the mean health expenditure per admission in the DRG hospital, which is the control, which is the treatment group, and the orange line shows the mean medical expenditures in the non-DRG group, in the control group. So it is kind of obvious, showing that after the reform, the gap between the two groups has shrunk. So that's the expenditure in the DRG group has decreased relative to the non-DRG group. And here is the regression results. The dependent variable is the log reimbursable expenditure. And the key control variable is the product of the DRG times the post. So here it shows that after the reform, the reimbursable expenditure in the DRG group reduced about 7.6% comparing to the non-DRG group. So that's the conclusion. So the next page shows you the event study. So it is obvious that I think the parallel trend satisfies, and after the reform, we see obvious, we see a decrease. We see a significant decrease after the reform. And then this figure shows the quantile regression on log reimbursable expenditures. And this fits our prediction too, that the reduction is achieved. The reduction would be greater for the patients with greater expenditures. So here we can tell from the 90 quantile patients achieved a higher reduction than the lower quantiles. So it's the greater the original expenditure, the greater reduction is achieved, which is intuitive, because under the fee-for-service, the patients with the higher expenditure may incur a higher level of overprevention. So the prospective payment tries to reduce the behavior of overprevention. So it's easier for those high spending patients to control their costs. That's why we observe this spending level heterogeneity. All right, then we decompose the expenditure into 4 different subcategories, including drug, examination, treatment, and nursing care. And from the that showed in the 4 panels, panel A to panel D. And from column 1, we can see that on the measure of log reimbursable expenditure, we can see that the reduction is mainly driven by the reduction on drug expenditure instead of the expenditures on other type of services. And this is also not surprising because for those of you who are familiar with the Chinese system, for a long time, the China has been an overuse of drug, overprovision of drugs, because it's a problem system that the price of the services are fixed, and the over provision on other services is kind of difficult. For example, the examination or nursing care, it's kind of hard for the physicians. It's not easy for the physicians to over provide the tests and examinations. For example, blood tests, consumers can, physicians, it's hard to prescribe like multiple same examinations for the patients. And the drug for a long time has been has occupied a large fraction of hospital revenue, and for the physicians, it is kind of relatively easy to overprescribe. For example, if the patients really need only need one type of drug, but the physicians would prescribe like 2 or 3 type of drugs to the patients. It's hard to tell by the patients. So it is a fact that overprovision is more prevalent among drugs compared to other type of services. So by implementing the cost containment payment system, we observed that the reduction on medical expenditure is almost solely focused on, concentrated on the drug expenditure, but not other type of services. That's our key finding in this project. And further, we decompose the expenditure into quantity and price. We conduct this decomposition by connecting how many type of drugs prescribed in a given admission, and the prices get by dividing the number, dividing quantity from the total expenditure, in order to examine whether the reduction is achieved through reduce the quantity of services or switching to cheaper services. And here, column 2 and column 3 answered the question that the reduction and the drug expenditure is mainly driven by the reduction on quantity, which also fits our previous, which also fits the intuition that overprovision in the traditional fee-for-service system is mainly through prescribing more types of drugs to the patients. So the cost containment patients correct the inefficiency by reducing the quantity of drugs consumed. Also, this also fits to our model setting. Still remember the lambda, the parameter, is the responsiveness of the overprovision for the patients. We can view lambda, we can view that different subcategories fits different lambda. As for the drug, lambda is kind of small because patients, it's hard to tell whether many types of drugs is necessary. However, it's relatively easy for the patients to tell, this examination may be unnecessary because I have taken the same examination yesterday. So lambda for other services may be big. So that's why we have the prediction that the reduction is achieved through the ones that is less responsive, and hence overprovision is more prevalent in those categories, in those subcategories. All right, that's our main finding. And then further, as mentioned before, we go into more detail on the type of drugs. Type A and type B. So in China's insurance design, there are two types of drugs. Type A, in Chinese, it's 甲类, and type B is 乙类. Type A drugs usually meets the basic medical needs. Usually it's have lower prices, it's more cost effectiveness, and it's determined by the central government. And for the type B drugs, local government have some flexibility to add or delete some drugs in the type B list. Usually, type B list of higher price and is viewed as less cost effectiveness. So in the previous, traditional, in the pre-reform period, overprovision of drugs is more likely to happen in on the type B drugs because they're more expensive and they can generate higher revenue for the hospitals. So this policy implementation in general decrease the use of type B drugs instead of type A, which try to meet the basic needs. Right? Again, it's intuitive that type B drugs, the less cost effectiveness drugs has the most reduction, and which is also, I think it's a nice result that the less cost effectiveness drugs has the reduction instead of drugs which meets the basic need, because in that situation, if the type A drugs has reduction, which may affect health outcome. All right. And then we come to examine the non-reimbursable services. From column 1, we can see that non-reimbursable expenditure in general has no impact, largely because it only has a small fraction in the total expenditure. It's positive. The coefficient is positive, but it's not statistically significant. And the total expenditure is mainly driven by the reimbursable expenditure we showed many slides ago. And the conclusion is that the total expenditure reduced about 7.3% after the reform. And then we try to see a more general picture about the hospital's revenue. So we come to see the number of admissions and also the potential impacts on the outpatient care. We'll introduce it one by one. In the table 10, at column 2 and column 3 shows the impacts on the number of admissions. Column 2 shows the number of admissions per hospital. It increased about about 9. The mean of the dependent variable is 90, so it's about increased about like 10%. And column 3 shows the number of unique patients per hospital. So the combination of column 2 and column 3 shows that a number of admissions increased, and this increase is mainly driven by attract more patients to the hospital instead of having the same patients have multiple hospital stays. So that's inpatient. And the combination of the increased patients and reduction and per episode expenditure shows that in column A, in column 1, the hospital revenue from the service provision remained almost the same. It's unaffected. Maybe have like a reduction, but it's not statistically significant. So it's the column 1 shows. We further examine whether there's any outpatient spillover effect on outpatient, and the answer is yes. Column 6 and 7 shows the number of visits per hospital, number of outpatient visits per hospital, and it shows that number of visits increased significantly after the reform. And column 7 shows that number of unique patients also increased significantly after reform. So the conclusion is that due to the pressure of revenue reduction, the hospital seems not only increased the number of admissions from the inpatient care, but also increased the admission from outpatient care. And column 5 shows that the hospital revenue increased significantly, about 7.7%. And also I forgot to mention that column 6 and 7, the combination of 6 and 7 shows that the increased outpatient visits is driven not only by attracting more patients, but also to have the same patients visit more times to the hospital. And then the total revenue on column 9 shows that the total hospital revenue remained the same. The total hospital revenue is the total of inpatient revenue and outpatient revenue, and it's in general unaffected. So that's the evaluation on hospital revenue. And finally, we conduct another 2 dimensions analysis. First is potential outcome, because we only obtain the claims data, so there are only like limited measures on health outcome. We use 2 measures: the death in hospital and the readmission. Readmission defines as the patients are readmitted in the hospital within 15 days for the same diseases. And it shows that there are no significant impacts on either the death in hospital or the readmission. And in addition, we also tested the length of stay, and no significant impacts. Oh, sorry. So readmission is for whether readmission within 30 days instead of 15 days. These are the results. And finally, we check some potential provider manipulation behavior. So in the US literature, there are like a large number of studies studying whether prospective payment scheme has caused some provider manipulation behavior, such as upcoding or claim skipping. Upcoding says that the providers would code the diagnosis from the lower weight group to higher weight group in order to receive receiving higher payment. As I showed you in the illustration slides. So here we examined this pattern. The dependent variable is the fraction of top codes. So the idea is that if upcoding happens, we would observe that the fraction of top codes increase after reform. So therefore, column 1 shows the results, suggesting that it seems that upcoding is not conducted at the place during our research period. And the second column is we restrict our sample to the first quarter of largest spreads, saying that because there is difference between the top codes and the normal codes. The greater the weight difference, the higher incentive the provider would have for upcoding. So we pick up the groups that with the largest weight difference, and to check whether the fraction has increased or not. And fortunately, we do not find the evidence on upcoding. So here, why the upcoding is not found? First of all, it's only a limited evidence here. We do not find the evidence does not necessarily mean there is no upcoding, but there are some potential possibility. There are some reasons that could support no upcoding is found. The first is that because upcoding is popularly found in the developing countries. So when the DRG scheme is applied in China, the government applied a strong supervision in the system. So that's why the hospitals their behavior maybe is more regulated, maybe than many years ago the scheme implemented in other countries. So strong supervision may be one reason explain no upcoding. And the other reason is that maybe it's likely that we only have about like 1.5 years research period. It is possible that the DRG system is quite complicated, that the physicians hasn't been familiar with the system, hence they are not able to gaming it. So if we have a longer period of time, we may find upcoding in the future. So another concern is that it's due to the timing. There are like 2 reasons. An additional one may be it's quite, although it's unlikely, but it's kind of it's also one reason that in general we have like public hospitals in China. Over 80% of the institution of the admissions that occurred at public hospitals. Physicians are employed by the hospitals, and the hospitals that they bear a lot of like public services. Maybe the incentives to over prevention is to upcoding is less than those in other systems. That's kind of potential reasons for no upcoding is observed. Okay, last is that we also examined the transfer, saying that conditional on that no upcoding is observed, we try to examine the cream skimming. Cream skimming and transfer. Cream skimming means that because the payment is fixed, hospitals may have incentive to dump the most severe patients. They refuse to accept the most severe patients, which would expect to make loss for their profits. Conditional, there are no upcoding. We regress the weights and the regression and find that the weights there's no reduction on the weights. Also, we examine the transfer, whether to examine whether the DRG hospitals are more likely to transfer the severe patients to other institutions. Again, we do not find the evidence on transfer patients. And the third column shows that in addition, we add a product and the severity on top of the product and DRG and post. Try to examine whether the severe patients are more likely to be transferred out. And it shows that, again, we do not find the evidence on the transfer. All right, that's all the results. So for the brief conclusion is that we find the reimbursable medical expenditure per admission declined about 7.6% after reform, and the impact is greater for patients with greater medical expenditure, greater medical spending. Most of the reduction is attributed to the change of drugs, which have been over-provided before the reform. And we find almost no expenditure reduction on other type of services, including tests and examination, treatment, or nursing care. As for the quantity price decomposition, we find that the aggregated reduction in the expenditure is fully explained by the change of quantity. Let's say that it's the reduction of quantity, but not to switch to cheaper services. And the drug use reduction is attributed to the reduction in the less cost-effective drugs, which is the type B drug, but not on the more cost-effective drugs, which is the type A drug. The number of admissions increased by about 10%, but the inpatient revenue or total hospital revenue are unchanged because we know that the per episode expenditure is decreased. And finally, there are like spillover effect on the outpatient care that we observed the volume increased for outpatient visits. We do not find evidence on the potential behavior response on upcoding or cream skimming. That's all I have. Thank you.
Great, thank you so much. Very interesting research on a very important topic. So listeners, if you have any questions, go ahead and add those. We have a clarification question, Julie. You could stop sharing slides if you want to discuss, or if questions about the slides come up, we can look at those. But this clarification question is, how do you separate drug examination and other spending in the post period under the DRG payment system?
The data automatically separates because so it's a data issue. So in the data, we have the detailed claims data. It shows the details of the item level services. So each record shows the item. For example, if it's a drug, it's a drug. It provides the price of the drug, quantity of drug, and the total expenditure. So we are able to classify all the records into the drug, examination, tests, and nursing care.
Right. So, and you think providers have the same incentive to code all that, even though they're being paid a bundle?
I don't think the classification would affect the payment. It's in the system. It's when the providers prescribe, for example, when the provider prescribe a particular drug, this record is automatically submitted to the insurance system. And the payment is a different like a calculation. So the claims it's for the records.
Right. Okay. Well, going forward, maybe there'll be some probing into that question about whether they have the same incentive to record. Maybe if you could stop sharing slides, we can have a few questions before the end of the webinar. Another question that's come in, thank you for an excellent talk. As these findings are for secondary hospitals, he wants to know what proportion of hospitals are secondary as opposed to tertiary, and would you expect effects to be different in tertiary hospitals?
Oh yeah, sure. Yeah, so in China, there are like 3 levels of hospital system. There are like 3 tiers. The most comprehensive ones are the tertiary hospital, followed by the secondary hospital, and the first as well as the township health centers and community centers, the 3 tiers. The most comprehensive ones are the tertiary, usually treating the most severe diseases. And for the secondary hospitals, there are like a large portion. I don't remember the exact number, but the fraction of the secondary hospitals must over 50%. Should like occupies a large fraction in the system. Usually the county hospitals in the medium level county are secondary hospitals. And only those like relatively large cities has its center hospital at the 3rd level. So in general, the 3rd level hospitals it's likely to perform differently than the secondary hospitals. So that's why we exclude the only 2 tertiary hospitals in our sample.
Okay, great. Please stop screen sharing. Just a few more questions. It's great that you were able to look at in-hospital mortality and readmissions. I'm hoping someday people will be able to link to overall mortality. Often 30-day mortality anywhere in hospital or out of hospital is used elsewhere. So hopefully that kind of linking to the general data. China has great vital statistics compared to many middle-income countries. Do you think there's any way of being able to link that data and look at overall mortality, maybe focusing in on the DRGs where mortality is relevant outcome?
Oh, it's a great idea. I guess you mentioned the population mortality is from the measure from CDC, the Quality Control Center. So what you mentioned is the mortality for the general population, not just the patients, right?
Well, if you could link by Hugo to the actual patient, you would know whether they died, whether it was in the hospital or elsewhere. Anyway, we look forward to you and your wonderful co-authors doing that someday. Another question, do the patients know that the hospital payment has changed?
It's a great question. We assume that the patients does not know, because it's a provider side payment scheme. Patients does not necessarily, it's quite complicated. So probably patients won't able to understand what's happening in a hospital. However, there might be some, like, patients may tell from some behavioral change, saying that because the payment changed the incentives, so hospitals are more likely to dump the patients, although we do not find it, but in practice, they may more likely to dump the patients, and some patients may learn that, okay, there may be some policy change, so I would automatically choose the non-DRG hospital instead of the DRG hospital. We'll check for that to see whether, like, after reform, there are distributional change between the patients. But in general, according to our knowledge, the change is kind of rare to the patient. The patients are rare to know about the change, because in practice, even some of the physicians are they didn't know don't know the change, so they just they're not familiar with it.
Right, thank you. So we have a question. These results suggest that the switch to DRG avoided basically all the negative consequences typically anticipated and found in other studies, this person is saying in their question. So do you have a sense of why the system was able to avoid those negative consequences? You mentioned that a key part of hospital strategy is to attract more patients. Where are these patients coming from, and how are hospitals able to attract them?
Oh, thanks for the question. They're great questions. The first is for avoiding the potential negative consequences. We are kind of surprised to see the consequence. As I mentioned just now, like, it is one potential reason. One reason could be like that. The government has strong supervision, because before the implementation, they're already aware that there might be some, like, upcoding or quim skimming behavior. So the supervision is that once those behaviors are found, the hospitals will be greatly punished. So that's one thing that we do not find like significant evidence. Another issue is we only have like 1.5 year post period data. Again, DRG is really, really complicated, and even the physicians learn to understand the system. They need time to understand it, so it may take longer time for those physicians to play the game. So that's for the potential. So we would keep collecting the data for a longer period for like a relatively longer evaluation. And for the second question, it's on the It's on the response. Yes, we find that hospitals attract more patients. For the inadmission, for the inpatients, they attract more patients. It is possible that they increase their turnover rate, they increase their number of beds, so they are able to receive more patients. And for the outpatient care, they both attract more patients as well as to have the same patients visit the hospitals more times. So we plan this is really a great question. Well, what we haven't done is that to see how does this increased volume come from, whether they're from the non-DRG hospitals or they're from the population who has never visited the hospitals before. So it means that whether they are like switching or they attract a new wave of patients. That's that's the question we haven't answered, but we plan to do.
Great. Another question. In your study, did you also look at medical consumables or medical devices?
That's a great question. Yes, we haven't. We haven't, but we could do. I understand it's like medical materials. Yes, in our current categorization, they are like just the nursing care, examinations, tests. We haven't, but we are able to do so because I understand why the audience raised the question, because medical materials is another potential subcategory that over-prevention is prevalent. So especially for some diseases. So we can check that. Thank you.
Great. In the spirit of checking other things, keep tuned, everybody, for further results. I'd be curious, have you ever tried to look at sort of specific conditions where that Q non-reimbursable is a higher fraction in the pre-period? Because you'd think that the bite of the payment reform would be greater when they don't have that non-reimbursable margin where you're saying they may be able to induce demand. So I'd just be curious about heterogeneous effects based on the pre-period part. I know it's pretty small part of the overall spending, but have you looked at that, or maybe you could?
We haven't. This is a great suggestion. We could do that. You're right that even in general, the non-reimbursable expenditure only has a small fraction, but in some particular diseases, it could be big, and they may have different impacts by the reform.
Great. Well, we'll look forward to what your whole team finds out later. We will close with just a couple other questions. Have you ever shared these results with policymakers and had any reactions there? And do you have a feeling about whether other pilots are being rolled out in similar ways or might have different results? Any final thoughts about those questions?
Oh yeah, yes, we have presented the work in some places, both policymakers, but mainly it's in academic, it's other researchers. There are some groups conducting the analysis on DRG. The most related one is I showed in the slides is conducted by the Professor Jianwei Yan, also in Peking University in School of Public Health. They show that or at least I privately talked with him. His opinion is that it's surprised to not observe upcoding in practice. His conclusion is that upcoding indeed exists in practice. It's just for some reason we do not observe it. So it's like this. And for other studies, we kind of reach a consensus that expenditure reduction exists, is proved to be exists with more or less pretty similar level. That's the policy has come to the expenditure reduction.
Great. Well, hopefully you'll continue to probe these results with this data and further longer term outcomes, more dimensions of quality, different patient groups, maybe looking at whether hospitals change their VIP wards or how they reimburse their physicians and the cascade of incentives. So many important questions to look at. But thank you again so much for sharing your research. Any final thoughts?
Oh, also, I had to make some supplemental information that, of course, in the future, we plan to show the results to the policymakers. And also, we have actually talked about the general impacts about the DRG to the deans of some like large hospitals in Beijing. Just give you some general background that here in Beijing, Beijing plans to implement the DRG for all its public hospitals, tertiary public hospitals by the end of this year. And the most hospitals is very nervous about the implementation because they know that this prospective payments may greatly reduce their control their revenue and affect their behavior. They tried very actively to understand how the system would work and how it would potentially change its physicians' prescribing behavior. So they take it seriously.
Indeed. Well, another reason why it's important to have researchers like you looking into the impacts and patient welfare in particular. So thank you so much for sharing your research with us, and thank you all for joining for the webinar today. We'll hope you would join for future events. Thank you again, Julie and Lisa. Thank you and goodbye.
Thank you very much for inviting me.